Hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is lecture number 13. Now, for the next series of lectures that we will be having for Applied Anatomy and Physiology, we will be specifically looking at metabolic processes, elimination, and reproduction. And so this will be the first lecture with respect to this topic. And now for today's lecture, we will specifically be looking at the respiratory system. And in our lecture today, we will discuss the learning objectives. We will look at key terms. We will talk about the structures of the respiratory system. We will also cover ventilation and respiration, followed by control and regulation of breathing, and we will look at aging and the respiratory system. Before we get started, why do your lungs feel like they are burning when you hold your breath for too long? Also, conscious breathing is an integral part of swimming or running, but it can also be key to meditation or mindfulness practices. Why is breath control so important to functioning at our best, both physically and mentally? The learning objectives for today's lecture are that upon completion of this chapter, the students will be able to list the functions of the respiratory system and discuss their importance as they relate to the practice of manual therapy, name the major organs of the respiratory system and describe their general structure and functions, classify the major organs as either upper or lower respiratory tract components, and define the processes of ventilation and respiration. Name and locate the skeletal muscles involved in ventilation and describe how each contributes to this action. Compare and contrast internal and external respiration processes. Explain how oxygen and carbon dioxide are transported in blood, and describe the physiologic processes involved in respiratory control and regulation. Here are the key terms that we will consider today: exhalation, external respiration, inhalation, internal respiration, respiration, respiratory membrane, and ventilation. We begin our discussion today by looking at the structures of the respiratory system. Breathing is a continuous process that reflects both the quality and tempo of life. From the first breath of air drawn into a newborn's wet lungs to the last sigh expelled before death, the rhythmic exchange of air provides cells with vital oxygen and eliminates carbon dioxide, a byproduct of respiration. Most of the time, breathing is not part of our conscious awareness. Yet, if we do not pay attention, the rate and depth of each breath can reliably indicate our physical, emotional, or mental state. Anatomically, the respiratory system is fairly simple, consisting of a network of large and small passageways that move air to and from the lungs, where oxygen and carbon dioxide exchange occurs. The system is divided into the upper and lower respiratory tracts. The upper respiratory tract consists of the nose, sinuses, pharynx, and larynx. The trachea, lungs, and bronchial tree are the primary organs of the lower respiratory tract. Both tracts are lined with highly vascular mucous membrane, the respiratory mucosa, which consists of pseudostratified columnar epithelial cells interspersed with mucus-producing goblet cells. This membrane warms and humidifies the air and traps small inhaled particles. The movement of cilia, which are small hair-like projections on the mucosal cells, moves mucus to the pharynx, throat, where it can be swallowed or expelled. And here we see illustrated the structures of the respiratory system, the upper respiratory tract and the lower respiratory tract. And here we see illustrated the structures of the respiratory system. The respiratory tract is lined with a mucous membrane that consists of pseudostratified ciliated columnar epithelium interspersed with mucus-producing goblets. The mucosa warms and humidifies air and traps inhaled particles in its sticky mucus. Cilia move mucus toward the pharynx, which is the throat, to be swallowed or expelled. And here we see illustrated the nose and nasal cavity of the respiratory system. The nasal cavity is divided by the nasal septum, created by the vomer and ethmoid bones, and a hyaline cartilage extension. The superior and middle nasal conchae are projections of the ethmoid bone, while the inferior nasal conchae are separate facial bones. The ethmoid and maxillary sinuses are also shown. And here we see illustrated the upper respiratory tract. A lateral section of the upper respiratory tract system shows the three segments of the pharynx, the nasopharynx, the oropharynx, and the laryngopharynx. The tonsils and the opening for the eustachian tubes are also found within the pharynx. And here we see illustrated key structures of the larynx and trachea. In illustration A, we see an anterior view which shows the thyroid cartilage that protects the larynx, as well as the cricoid cartilage and cartilage rings of the trachea. In illustration B, we see the superior view which shows the vocal folds, which are the vocal cords, and the glottis. In illustration C, we see the trachea cross-section which shows the C-shaped tracheal cartilage ring and the smooth muscle and esophagus that provide support to the posterior side. Now let's consider the lungs and the bronchial tree of the structures of the respiratory system. The lungs occupy the majority of the thoracic cavity and are situated on either side of the heart. The superior narrow portion of each lung, the apex, is located just deep to the clavicle, while the broader base of each lung rests on top of the diaphragm. Deep fissures in the external tissue divide each lung into smaller regions or lobes. The right lung has 3 lobes and is slightly larger than the left, which has only 2 lobes. The left lung is a bit smaller to allow room for the heart on the same side of the thoracic cavity. Like the heart, the lungs are surrounded by a double-layered serous membrane called the pleura. The visceral pleura covers the outer surface of the lungs, while the parietal pleura lines the walls of the thoracic cavity. The microscopic space between the layers is filled with pleural fluid, a serous fluid that reduces the friction as the lungs expand and contract during breathing. Pleurisy, an infection or inflammation of the pleura, increases the friction between the membranes, making every breath quite painful. The bronchial tree is a network of passageways inside the lungs. The right and left primary bronchi are the largest branches that divide from the trachea at about T5 to the vertebral level. Once inside the lungs, each primary bronchus branches into several smaller secondary bronchi, which then divide into even smaller passageways. In fact, the bronchial tree has 25 orders of branches. Similar to the trachea, the bronchi have incomplete rings or plates of cartilage to help keep them open. The smallest passageways are the bronchioles, which are small tubes with no cartilage in their walls. Instead, their walls are made of smooth muscle. The respiratory mucosa in the bronchioles is comprised of cuboidal instead of columnar epithelium with fewer cilia and goblet cells than the larger bronchi because most foreign particles have already been filtered out. The bronchioles subdivide into smaller alveolar ducts surrounded by numerous alveoli. These microscopic air sacs cluster around the alveolar ducts and look similar to a bunch of grapes. Alveoli are composed of a single layer of epithelial cells, just like the blood capillaries that surround them. Some of these cells produce a slippery substance called surfactant, which reduces surface tension within the alveoli to keep them open during breathing. Macrophages are also found in the alveoli to destroy any particles or microbes that were not trapped and expelled by the respiratory mucosa. Oxygen and carbon dioxide are exchanged between the air in the alveoli and the blood in the surrounding capillaries. This exchange occurs via diffusion through the extremely thin barrier formed by the alveolar and the capillary walls, collectively called the respiratory membrane. Since there are millions of alveoli in the lungs, there is a large surface area for gas exchange. In fact, if spread out flat, the alveoli would cover an area of approximately 750 square feet, which is much larger surface area than covered by the skin. So it's time for our first What Do You Think segment. And remember, the What Do You Think segments are designed to help you to start to develop your clinical reasoning skills as you train as a clinician. What everyday household items could you use to construct a model of the respiratory system? List each item and the anatomical structure it would represent. Now let's take a closer look at ventilation and respiration. Breathing includes two interdependent processes, ventilation and respiration. Ventilation refers to the process of drawing air into and expelling air from the lungs. While respiration relies on this mechanical process, they are not the same. The term respiration refers to the passive diffusion of oxygen and carbon dioxide. Although the primary purpose of breathing is gas exchange, ventilation and respiration also support several important homeostatic functions, including temperature regulation and the maintenance of pH and fluid balances. Pulmonary ventilation has two phases. Inhalation, which is called inspiration, which draws air into the lungs, and exhalation, also called expiration, which expels air, moisture, and heat from the lungs. Both phases result from changes in the shape and size of the thoracic cavity. These changes, produced through the contraction and relaxation of respiratory muscles, cause variances in pressure between the inside of the lungs and the external environment. Muscles contract to enlarge the size of the thoracic cavity, decreasing the air pressure in the lungs. This causes air to rush from the external environment, an area of high pressure, into the lungs, resulting in inhalation. Conversely, when these respiratory muscles relax, the size of the thoracic cavity decreases, raising the air pressure in the lungs, and exhalation occurs. Inhalation is always an active process created through contraction of the inspiratory muscles. Exhalation is generally caused by the passive relaxation of the same muscles and the elastic recoil of the lungs. But exhalation may also be actively driven through the contraction of expiratory muscles, such as happens when we forcefully cough. The muscles that lift and expand the rib cage facilitate inhalation, while those that depress and compress it are muscles of forced exhalation. But it is the contraction and relaxation of the diaphragm, the dome-shaped muscular partition that separates the thoracic and abdominal cavities, that has the greatest influence on the size of the thoracic cavity. When the diaphragm contracts, the center of the muscle is pulled inferiorly into a flattened position. This increases the size of the cavity, producing inhalation by decreasing the air pressure within the lungs. While the diaphragm is considered the primary respiratory muscle, there are several other muscles of ventilation, and they are the internal and external intercostals, the scalenes, the external and internal oblique abdominals, the sternocleidomastoid, the rectus abdominis, the pectoralis major and minor, and the serratus anterior. And here we see illustrated the muscles of ventilation. In illustration A, when inspiratory muscles contract, they elevate and expand the rib cage, enlarging the thoracic cavity. In illustration B, exhalation is generally a passive process of relaxing the inspiratory muscles. Forced exhalation occurs when the expiratory muscles are contracted. So let's now consider the manual therapy applications with respect to ventilation. Several muscles of ventilation are key contributors to neck and upper back pain. In clients who suffer from these chronic conditions, therapists often observe a forward head and rounded shoulders posture. This adaptation strains the muscles in the upper back and posterior neck and locks them into eccentric contraction, causing fatigue and pain. This posture also has a negative impact on ventilation because muscles such as the scalenes and pectoralis minor take on a major postural role and are less effective in elevating the rib cage. When this happens, breathing becomes shallower and other inspiratory muscles must work harder to ventilate the lungs. In these cases, reducing a client's chronic neck and back pain may depend on relieving muscle tension and fibrous buildups in the muscles of ventilation. Now let's discuss respiration. Respiration is the physiologic process of oxygen and carbon dioxide exchange. The method of exchange is simple diffusion, and the gases are transported by binding to the hemoglobin molecules in red blood cells or by dissolving in plasma. This gaseous exchange takes place in two locations: inside the lungs between the alveoli and the blood, in the capillary beds throughout the body between the blood and the interstitium. The exchange of oxygen and carbon dioxide in the lungs is called external respiration because the air inside the lungs comes from the external environment. In normal circumstances, the concentration of oxygen inside the lungs is higher than the concentration inside the blood. So diffusion down the concentration gradient will move oxygen out of the alveoli and into the blood, where it binds with the HB to create oxyhemoglobin. Simultaneously, carbon dioxide diffuses out of the blood and into the alveoli to be exhaled from the lungs. Internal respiration is the gas exchange between the blood and body tissues that occurs outside of the lungs. During internal respiration, oxygen needed to fuel cellular metabolism is released from the hemoglobin oxygen molecule, and the metabolic byproduct, carbon dioxide, diffuses into the bloodstream. Carbon dioxide is transported through the blood in three ways: as a dissolved gas in plasma, as a bicarbonate ion formed from carbon dioxide, and water. It is also formed when carbon dioxide binds with the hemoglobin molecule. Approximately 80% of carbon dioxide is transported by converting it into bicarbonate, while the other 20% is transported either as HbCO2 or as a dissolved gas. While CO2 is essential for regulating the pH of body fluids, excess levels interfere with normal cellular metabolism. So eliminating excess carbon dioxide is a key homeostatic function of the respiratory system. Now, in terms of the manual therapy applications with respect to respiration, when working with clients with respiratory conditions, manual therapists may need to position the client in a seated, semi-reclined, or sideline position to ensure ease of breathing. Therapists should be aware of changes in the client's breathing and avoid any technique or position that inhibits breathing or triggers respiratory distress. As a general rule, treatment should be avoided when a client is experiencing any type of respiratory infection. Reviewing the client's health history for allergies or environmental sensitivities is also important to avoid triggering breathing difficulties. It's time now for our second What Do You Think segment. Why do you think some muscles, like the serratus anterior and the pectoralis minor, do not contribute as much to ventilation as the scalenes and intercostals? What could you do to observe a client's breathing during a manual therapy session? How do you think you might use that information? And how would you alter a standard manual therapy session for clients with breathing issues? Now let's discuss control and regulation of breathing. Regular and rhythmic breathing is so subconscious that the complexities of the process are rarely, if ever, considered. While inhaling is a simple mechanical process of contracting the muscles of respiration, the rhythm, the rate, and depth of breathing are controlled and regulated by the nervous system. Two regions of the brain stem contain the respiratory reflex centers, the medulla oblongata, and the pons. These respiratory centers send commands to the inspiratory muscles via two key nerves. The following list outlines the specific roles of the nervous system components that coordinate breathing. The respiratory centers are the two small groups of self-excitatory neurons in the medulla oblongata set the basic rate and rhythm of breathing. A region of the pons, the pneumataxic area, regulates the breathing rate by coordinating the stimulation of the inspiration center in the medulla. In adults, a normal resting respiration rate is 12 to 18 breaths per minute. The respiratory nerves. The phrenic nerve innervates the diaphragm, the primary muscle of inspiration. The intercostal nerve sends signals to the second important group of inspiratory muscles, the intercostals. Stretch receptors. These are pulmonary stretch receptors located throughout the lungs, mostly in the walls of the bronchioles and alveoli. When the lungs are full and stretched, these specialized mechanoreceptors send signals to inhibit the inspiration areas of the brainstem, allowing exhalation to occur. The chemoreceptors. The strongest influence of respiration centers come from the chemoreceptors located within the walls of the carotid and aortic arteries. These receptors, known as the carotid and aortic bodies, stimulate the respiratory centers via cranial nerves 9, the glossopharyngeal, and 10, the vagus, and are sensitive to changes in blood levels of oxygen and carbon dioxide. The respiratory centers are stimulated by low oxygen levels and high levels of carbon dioxide. The inspiration-respiration centers are far more sensitive to carbon dioxide levels, so the signal for inspiration is more vigorous. This explains why we generally cannot hold our breath beyond a minute or two. Our illustration here shows the control and regulation of breathing. The rate, rhythm, and depth of breathing are controlled by respiratory centers in the pons and medulla oblongata based on input from the chemoreceptors in the carotid and aortic arteries and stretch receptors in the lungs. These brainstem centers stimulate muscles of inhalation via the phrenic and intercostal nerves. Let's now consider the manual therapy applications with respect to control and regulation of breathing. Neural pathways from the respiratory centers in the brainstem and the cerebral cortex converge on the respiratory nerves, enabling both reflexive and conscious control of breathing. The depth, rate, and rhythm of breathing unconsciously change with different thoughts, emotions, or physical experiences such as pain. The reverse is also true. A conscious shift in breathing can modulate our thoughts, emotions, and physical experiences. Since there is such a strong link between emotional state and breathing, in many manual and movement therapies, conscious breathing is used to promote relaxation. Slow, deep, rhythmic breathing is extremely calming to nervous system and nourishes the mind and spirit as it provides the body with vital oxygen and relieves it of carbon dioxide. Integrating some type of breathing practice into daily life can also calm and renew the body, mind, and spirit. We are literally inspired and more creative when we make time for conscious deep breathing. Here is our third What Do You Think segment. What could cause a client's breathing to become rapid and shallow during a manual therapy session? Why do you think the strongest stimulus for inhalation is related to carbon dioxide levels? Let's now consider aging and the respiratory system. As the body ages, lung tissue becomes less elastic, the number of capillary networks in alveoli decrease, and the respiratory centers become less responsive to changes in oxygen and carbon dioxide levels. Age-related changes in the skeletal system, such as osteoporosis and calcification of the costal cartilage, make the thoracic cavity more rigid, which decreases ventilation capacity. This rigidity of the chest wall may cause the respiratory muscles to weaken, further diminishing respiratory function. Older adults also become more susceptible to respiratory diseases, including pneumonia and bronchitis, because macrophage activity in the lungs decreases and the number and activity of cilia declines. This makes it difficult to expel pathogens trapped in the mucous membrane. Age-related decline in respiratory function can be slowed or minimized through positive choices such as not smoking, maintaining a healthy body weight, practicing conscious breathing, and engaging in an active lifestyle. Time now for our pathology alert, where we will be looking at asthma and chronic obstructive pulmonary disease, or COPD. There are many chronic conditions involving the lungs and/or the bronchial tree that cause respiratory discomfort or distress. These include asthma and chronic obstructive pulmonary disease, or COPD, an umbrella term that includes chronic bronchitis and emphysema. With all these conditions, either temporary or permanent structural changes block airflow or the exchange of air in the lungs. Asthma is characterized by attacks of shortness of breath, wheezing, and coughing caused by reversible inflammation and secondary spasm of the smooth muscle of the bronchioles. The bronchioles of people with asthma are chronically inflamed and hypersensitive to allergens and other irritants. When irritated, the bronchioles sympathetically dilate and then reflexively spasm, making it difficult to breathe. Anxiety and stress can exacerbate the symptoms of an attack or serve as an additional trigger. Chronic irritation of the bronchial tubes due to asthma, allergies, multiple infections, smoking, or environmental pollutants can lead to chronic bronchitis. This long-term irreversible inflammation of the lining of air passageways is characterized by a chronic cough and increased susceptibility to respiratory tract infections. Chronic bronchitis can lead to or occur together with emphysema, a condition in which the walls of the alveoli first become less elastic and eventually break down, fuse together, and thicken into fibrous connective tissue. The breakdown of alveoli decreases the overall surface area for gas exchange and requires great effort to obtain enough oxygen and to expel air from the lungs. Therapists working with clients with COPD may need to adjust the duration of the session and position the client to ensure that they can breathe comfortably. Okay, so we've reached the end of today's lecture, and for assignment number 13, we are going to be using the Thinking Beyond format to do this assignment. What visual clues would you look for in a client that would indicate if breathing is shallow or deep? What would you feel under your hands? How might hypertonic scalenes and sternocleidomastoids, which are prevalent in our current culture, affect one's ability to breathe? And breathing can serve as a metaphor for letting go of what is not serving the body and receiving what gives it life. Holistically speaking, how might this concept relate to your life and the lives of those around you? And as always, this assignment is due by this coming Sunday at 11:55 p.m. If you have any difficulty whatsoever with this assignment, you may send me a text message or an email. My office hours are on Thursdays from 4 to 6 p.m. And with that, I will see you in the next lecture.